Historically, your sunburns, your first-degree burn, okay, does not go through the dermis. It does not break the epidermis, okay, it's just red, it's hyperemic, okay. It is painful, but because there isn't a breakdown in the epidermis, it's not necessarily as painful as, say, the second degree or the superficial and deep partial burns, okay. So everybody's had a sunburn in this room. Pretty sure everybody's had a sunburn, right? They're pretty painful. Normally heal within 3 to 4 days. Normally they do not scar. Okay, we manage it with just Tylenol, NSAIDs, and we, use aloe-based lotions. We try to avoid the alcohol-type lotions because those can burn. But aloe-based is really good. Okay, now we get into more superficial and deep partial burns. Okay, these go through the epidermis. Okay, and into the papillary dermis. These are the blistering. Okay. Now the hallmark between superficial and deep is if we have any of that centralized clearing that may be not as bad as third or full thickness, but it's like really, really painful, extensive. You have starting to see the loss of maybe some hair follicles, okay? Like the top one is maybe a partial or superficial partial, and the deep is a deep partial. Okay. Superficial, right? Normally heals within 2 to 3 weeks. Minimal scarring. Okay. You still want to treat it as if it's an open wound, so we keep it clean, daily washing. We try to keep it covered with aloe-based ointments. These are very, very painful, so you may need to give them a few days of narcotics, low-dose narcotics. Okay, it really just depends on how much of a pansy they are. No, I'm kidding. But these can be more painful. Okay, deep partial, absolutely you're going to want to have some sort of pain management on board. Theoretically, they don't necessarily need to be admitted unless it is a extensive, probably more than like 10% total body surface area. Okay. For deep partial, normally heals within 3 to 8 weeks, so a little bit longer, right? The more skin you burn, the deeper that burn goes, the longer it's going to take to heal. And with those deep partials, you start to then seeing more severe scarring, more contraction, okay, or contractures, loss of function, okay. When we get into those deep partial, we try to at least keep very, very close follow-up on these within the first few days, because again, like I said last time, these may blossom into worsening. They may blossom into actual full thickness. Okay, and if that happens, then remember we have to do that surgical excision of that area. So this area right here, right, this lighter area is possibly blossoming into that full thickness. So this is going to be one that we follow up very, very closely. And if it truly enters into that third stage, or that full thickness, that's going to have to be excised. It's never going to heal correctly. Okay. So any partial thickness of any depth that is not healed by 3 weeks, normally we have to go in and do some sort of a skin excision and possible grafting. All right, deep partial, again, what are you guys going to be doing in terms of like primary care? They show up to your clinic. Clean the wound, okay? If the blister is still intact, do not rupture it, or what we call ungrouping, okay? If the blister is still intact, you leave it alone, okay? If it's not still intact, you have to really carefully debride that loose tissue, or to send them to the ER, okay? Sometimes, depending on if it's super deep, you may need to have some sort of a narcotic on board to actually debride them, especially if it's over a joint, hands, feet, groin, face. We may actually need to do that in the OR. Okay. If you, whether you debride or not, okay, whether you leave the blister intact or not, you can cover with the Silvadene, which is an antibiotic cream. Okay, it's white, it's kind of thicker, has a sheen to it, reminds me of like kind of fluffy ointment or fluffy cream. It's really thick, but we'll go into medications in a few slides, okay? You're gonna place a protective dressing, okay? And what do I mean by protective dressing? Especially if that blister is open, you're gonna use Telfa, a non-adherent gauze. Okay, these wounds are going to weep. And if you just use regular cotton gauze, it's gonna stick to that wound, it's gonna stick to that burn, and every time you have to change that dressing out, which is every day or every twice a day, it's going to be extremely painful trying to get that gauze off. Okay? Ensuring that your tetanus is up to date, patient education, protection from sun, okay, is really, really important. We don't want these people back out into the sun for at least 6 months. Again, daily dressing changes, and then for both superficial and deep, or large, and they have a large TBSA over joints, hands, feet, groin, we send to the burn center. Okay, so if at any point in time you do not feel comfortable, just send to the ER, and the ER will take over to send them to make sure that they have either a follow-up at a burn center or with a burn surgeon, or you know, whatever they need to do. Okay, I've had a couple that showed up. I don't remember where I was. I think it was in Yuma. Either way, but we had to contact the larger burn center and kind of talk to them and do a consult over the phone, and they were like, yeah, this sounds like we could you know, see them in clinic tomorrow, just make sure this member gets there at 8 a.m. tomorrow for the burn clinic, or hey, no, this really needs to be seen tonight, go have them head up to the burn center tonight. Okay? Alright, full thickness, remember this extends through the entire dermis, okay, and into the subcutaneous. So your epidermis is completely gone, your dermis is gone, and now you're into subcutaneous tissue. Okay, they're normally white, dry, and painless. They can be black if it's necrotic and or just like singed, burned skin. Okay, if it was open, if it was in direct contact with a flame. Okay. Sometimes they appear red, but you really have to distinguish this from superficial burns because they do not blanch. Okay, your capillaries are all gone. Your nerve endings are all gone. Okay, they're not moist. They're very leathery in appearance. The skin is. Okay, the skin is actually a little bit thicker. It loses that elasticity. You know, right now you think of your breathing. Okay, if you have a third or full thickness burn around your entire chest, that elasticity that allows us to expand our chest to actually breathe no longer has that contracted or that elasticity, and so sometimes we have to do you know, treatments called an aspirotomy to open up that burned skin so that it allows for that movement of that chest, okay, which we'll go over. Most of the time we will treat these with excision and grafting, meaning we excise all of that third degree or full thickness burn, and then we will take healthy skin from a different part of their body and transpose it and graft it onto that burned area. Right? Really, time is skin, right? We, especially for those eschars, we want to get them off of the skin. We want to try to do that excision and grafting within the first few days, especially if they're kind of in between that, like if they're kind of in between stable and unstable. We definitely want them more stable before we take them to the OR, because we're about to do a huge amount of body shifts, their body fluid shifts when we go and do those excisions. And a lot of times, especially the more TBSA burn that they have covering their body, the more the kind of the longer these surgeries take. We'll normally try to do all of them all at once, and so they're all kind of at the same stage of healing. The only difference would be if we have no skin left to actually take that graft from, and we have to wait for that skin to regenerate or use a different type of tissue, which we'll go over in terms of like how to actually treat it. Okay. All right, full thickness burns. So these are again same as partial thickness. We're going to rinse with clean water. We're going to dress. We're going to elevate. You guys are going to potentially cover with Celadine antibiotic cream. You're trying to, if it's on the fingers or toes, you're putting gauze or that telpa in between to try to keep the digits open, because at this stage, if you were to make them a mitt, they're actually going to stick together. And then we'll have to actually go in and excise the skin between the tissue, or between the fingers, to actually give them a hand again. So absolutely bandage between the digits, okay? These people you absolutely must send to the ER or to a burn center. Okay? These are not something that any third burn, any full thickness burn, even if it's the size of a quarter, should be seen by a burn surgeon. The greater the total body surface area, the more that aggressive fluid resuscitation occurs. So normally it's really about, when you get to about 20% of total body surface area. So think about that, right? In our rule of nines, that's like basically a chest, an abdomen, or a chest and like back of your chest and the back, okay? One full leg. That's not that much, right? In the grand scheme of things. So it can add up. So if you are even close to 20, they should absolutely, on any, from superficial partial, deep partial, full thickness, if you are adding those up and it's close to 20, you should be sending to a burn center. Okay, even if the majority of them are superficial, they can always blossom into worseness. Okay, more than 20%, we really have to do aggressive fluid resuscitation, and those should be in a burn center. All right, we have 34-year-old female sustains a thermal burn. While counseling the patient, which of the following features is best associated with a second-degree deep partial thickness burn? What do you think? Deep partial.
Okay.
Alpha. Anybody think anything different? Good. Alpha. Alpha is correct. Rolling Hills, 21 to 30 days. Good. All right. So this is a FYI slide. Okay. This is a good to know slide, so that you can have at least some education and some knowledge on, initial assessment triage, fluid resuscitation within the first 2 days. How we're gonna cover burn coverage, supportive critical care, and rehab. All right. Acute resuscitation. We have a very, very low threshold for intubation of these people, especially if their TBSA is over 20%. Okay. Once we get over that 20, we know we're going to be giving them mass amounts of fluid. Like, I'm talking liters within the first 8 hours. Okay, multiple liters. So when we get to that point, right, and we're giving, if you have just a normal patient, okay, with normal physiology, and you give them 8 liters in 8 hours, what do you think is going to happen to their vasculature? They're going to swell, right? It's going to third space because your vasculature can't really handle that amount of fluid in a normal physiological state, right? So you are going to swell massively, and so when you swell, it doesn't just go to your hands and legs, right? It's everything. You're going to lose that airway very, very quickly just from the edema, from how much fluid we have to give them. Okay, so we preemptively and protectively actually intubate these people, whether they have inhalation injuries or not. If they have over 20%, more than likely they're going to get intubated, at least for the first few days, so that we can protect their airway from then it becoming an emergent type airway. Okay. If any of you get to go to a burn OR, be prepared, okay? It is extremely warm. They keep it over 100 degrees, okay? When we are doing burn excisions, the patient is basically completely uncovered. So we need to, they lose that, that skin barrier, right? They lose the ability to thermoregulate. So whether we're doing surgery in the OR or if we're in their ICU room, okay, we keep those spaces extremely warm to help them thermoregulate, okay, because they've lost the ability to. We'd rather them be warm than cold. Okay? So the space will be warm. We'll put blankets on them. We'll put you know, burn blankets on them to keep them warm as much as possible, bear huggers, all that thing. Increased fluid loss, okay? Just like with, you know, you lose that epidermis, okay, the dermis will weep. If you have a large scale of dermis that's gone, or damaged, okay, you have widespread weeping. So, in terms of that, we really, you know, and in terms of like the fluid resuscitation that we're gonna do, we use urine output as a guide, okay? I know the slide says 8 hours, that is the book, the textbook answer, but theoretically in our centers, our burn centers that have what's called a burn navigator. It is a computer program that we can put in how much TDSA they have, what fluids were given, what their urine output is, and then it tells us hour to hour how much we need to change their fluid, if we need to give them more fluid or decrease their fluid, okay? If we don't have that burn navigator, you know, we'll try to stick within, what we want to say, we want to stick to more of like a 1 milliliter per kg per hour. At least one. It's been a minute since I've had to calculate it, but we're going to go over that in a minute. But either way, we're using that urine output as our actual guide to fluid resuscitation. Okay? We can use invasive, we can use ABGs, we can use the ART lines to help guide our fluid resuscitation and manage their blood pressure. We can use lactate and Swan-Ganz catheters. Not really a thing in trauma anymore. Again, like we talked about in the thoracic lecture, that's more so what cardiothoracic surgeons use. All right, and then lastly for this slide, carboxyhemoglobin. Carboxyhemoglobin is a component of a byproduct from carbon monoxide. Okay, this is basically that carbon monoxide is being, you know, has an affinity for the hemoglobin. Okay, and so what we can do in order to actually, instead of the SPO2 or SO2, the pulse ox thing, right? It may say 100%, but who knows how much of that is actually carbon monoxide? This is how we tell. Carboxyhemoglobin is how we tell how much carbon monoxide is actually in the system, okay, versus the pulse ox. So we run it with the ABG. Okay, it's a specific cartridge within the ABG. Okay. Now the only thing is that if they are a heavy smoker at baseline, because their body's going to have more carbon monoxide in their system just from smoking, it's going to be falsely positive. So we just have to keep that into take that into effect. Okay. All right. So pathophysiology of burns. Okay, rapid loss of that intravascular fluid and protein through those heat-injured capillaries. Okay, we lose the greatest amount of that intravascular fluid within the first 6 to 8 hours. So that is when we actually give the most, like the massive amounts of fluid within the first 8 hours. Okay, but we will continue going until they are stabilized. All right. Edema is due to that hypoproteinemia from that loss of that protein through the injured vessels. Okay. Another thing that we have to worry about is systemic inflammatory response. Okay. Just like when you have scrape, right? You have a massive amount of white cells and inflammatory response going to that area. Now think if you have more than 20% of your body, say 80% of your body that's now injured. Okay, you have a massive inflammatory response. Okay, this also leads to that extracellular shift of sodium and water where it's not supposed to be. Okay, they are at high risk of acute kidney injuries. Okay, just due to these high volume fluid shifts. It's kind of sometimes funny because we'll be running like 200 mils an hour of NS or LR, and but their kidneys are still shit, and so we have to give them, and then because of that, their blood pressure tanks, so we have to give them pressors, even though we're giving them so much fluid per hour. So it's really a delicate balance when we get to higher level TBSAs, because it is just very, very hard. If you ever get to go to a burn ICU, those are like the creme de la creme of like critical care trauma or critical care people. They have to deal with a lot of physiology. Again, smoke inhalation may increase that hemodynamic instability, fluid requirements, mortality rates, right? You have, 50% TBSA on the outside, but then you get smoke inhalation, maybe you burned your lungs, okay? That also increases that weeping, right, inside of your wound, inside your lungs, from open wounds, or they're so burned in the inside of your lungs that you're not having that oxygen exchange that you're supposed to. So smoke inhalation is a big, big deal. All right, primary goal, okay, we want to prevent burn shock. That is hypovolemia plus a cellular shock. Okay, we want to prevent it. That is our main goal. What burn shock is, we have a decreased cardiac output, but also an increased extracellular fluid. We have a decreased plasma volume and no urine. Okay? So we want to restore and preserve that tissue perfusion, and we want to avoid ischemia and worsening tissue injury, which is a very delicate balance sometimes. Okay? Because of that depletion of plasma volume, after a while, because the capillary beds are so leaky, however much fluid we give them, or crystalloid type of solution, we may need to add a bigger type of solution called albumin, which is a bigger protein which actually stays intravascularly. Right, so we can actually increase their intravascular volume without risk of it going extracellular or extravascular. Okay? That's a little bit further down the road, but again, initially we give lactated bringers. Okay? Resuscitation goals: we want to provide enough fluid for organ perfusion, but without causing complications from hypervolemia. Very delicate balance. Okay. All right. So, how do we know how much fluid to give and when? Right? What's our cutoff? The next two slides are two different types of formulas that we can use. I'm more familiar with the Parkland formula and the modified Parkland formula, but I want you guys to know how to calculate this. Okay? So the Parkland formula is 4 mLs times that percent of TBSA that the patient has, times their body weight in kilograms. Okay, so I have an example. Right, you have a 70 kilogram patient. They're 40% TBSA, so 4 times 40 times 70 is 11,200 milliliters. Okay, we give that within the first half. Right, so that's 5.6 liters that we're giving within the first 8 to 16 hours, 8 to 12 hours. Okay, so again, that's 700 milliliters an hour for the first 8 hours. That's maximum, right? That is that. I don't think anybody has a small enough bottle, but 700 milliliters. That's basically almost a normal wine bottle. A wine bottle, a normal size wine bottle, is 750 mLs. Don't ask me how I know that. So imagine that every hour for 8 hours, right? That's a lot of fluid, okay? Now we do adjust urine output to 0.5 to 1, right, kg per hour, okay? Again, we want it around 1. If it's above 1, we'll decrease. But as long as it's around 1, that's normally the sweet spot. Okay? All right. Any questions on Parkland? All right. Let's go to the world tens. Okay. So this is a little bit more tricky-ish. Depends on how well you know math. Okay. So you do 10 milliliters times their TBSA, and then times the hour. Now, the only caveat to this is it only really works if they're over 40 kilograms and less than 80. Okay? If they're more than 80, say they're saying 90 kilograms, okay, and they're 40% TBSA, you start off with that 40 times 10, which then you get 400 mils an hour. Okay? But now you have to add an additional 10 or an additional 100 to that 400 in order to account for that extra 10 over the 80 kilograms. Okay, so their end is actually 500 milliliters per hour times 8 hours, which is then 4 liters. Does that make sense? Okay, so if they weighed 100 kilograms, you're gonna have the, and they're still 40% TBSA, they're still gonna be starting with that 400 mils per hour, and you're gonna add 200 mils per hour, so then that goes up to 600 mils per hour. Does that make sense? Okay, so as long as you do the 40 times 10, or the TBSA times 10, okay, if they're less than 80 kilograms, anything above 80, you add an additional 100 mils per hour per 10 that they go over 100, or over 80. Okay, so again, it took me a minute to really wrap my head around that one, because I don't use this one ever. Does that make sense to people?
We had it on today's
We
test.
just learned it, man.
Well, we got it wasn't on. Oh, well, yeah.
No. Alright, so a patient suffered a 45% second degree burn. Okay, it is resuscitated with the Parkland formula. What is the following is the best parameter to monitor adequate volume resuscitation? How do I want to monitor volume resuscitation?
Urine.
Urine. Alright. Specifically to wound care, okay, really depends on the level of burn. Okay, with superficial burns, like I said, we're going to use lotions, ointments, aloe, mild pain meds, Tylenol, Motrin, that's fine. Superficial partial burns, okay, we want to try to, because that dermis or the epidermis is now open, okay, is a breeding ground for infection, so we want to keep it as clean as possible. Okay, this is daily washings. You know, normal. It can be a shower. It can be normal tap water as long as it's got a antimicrobial or antibacterial soap. I really love Dial. It's a mild antibacterial type soap, and it works very well. Okay. We don't necessarily treat with topical antibiotics. Unless it starts to look like it's becoming infected. Okay. Occlusive dressings to minimize exposure. Really just depends on how bad it is and the extent of it. Okay, the exception is the face. We normally treat that with bacitracin. Okay, and if it's around the eyes, like you'll see in another slide, we want the ophthalmic bacitracin. Okay. If it's just on the chin, you can just do normal bacitracin, but anywhere around the eyes, you want to do that ophthalmic. Okay. Deep partial to full thickness. Okay. We really want to prevent that invasive infection. We want to remove that dead tissue as soon as possible. We want to cover the wound either with skin or skin substitute. And then all topical antibiotics really limit wound healing. So with that Salvadine and like comparison, we really try to limit that to those who absolutely need it. Okay. So topical antibacterial type agents, okay, they only go superficially. They only really goal is to create a moist environment. Okay. Really protects against that microbial colonization. We do not give systemic antibiotics unless you come in and you're cellulitic. Okay, just think of these as like normal abscesses, right? As soon as we get that source control, that's good. We don't need antibiotics unless they come in with a cellulitic type process. Then that's when we need to start giving antibiotics. Okay, silversaladine, okay, is the most commonly employed one that we use. It's that white one that you see that guy applying. That person applying. Broad spectrum, works really well. The only problem is that it can cause a transient leukopenia. So if it's widespread, we always have to then check, make sure that their CBC is not showing any abnormalities if we are using it long term. Sulfamylon, okay, these are what we use in terms of cartilage. So we use it a lot on the ears, the nose, anything that has a significant amount of cartilage in it. Okay. And then again, ophthalmic bacitracin for around the eyes, bacitracin for all the rest of the face. Okay, all right, debridement. We really want to debride all the loose skin and dirt. Okay, if you're doing this in the clinic, we're doing it by body area. Okay, we want to try to keep that patient as warm as possible. So in a big clinic or in an ER setting, sometimes that's very hard to do because it's an open bay. You can't really make the temperature in the ED any higher. Okay. Normally we give IV narcotics for these, and then we give tetanus. Okay, we have 17-year-old female seen in the emergency department with 3rd-degree burn, which is a what? Full thickness.
Full thickness.
Okay, it happened on her foot 8 days ago. She now has an eschar covering most of the wound. She is febrile. She has an elevated white blood cell count. What's the following most appropriate next step in managing this patient?
B. That's what's so proper.
What do you guys want to do?
Okay, cut that skin out.
Is this something you want to try to do in clinic?
Boo.
No clinic. Okay. Are we only going to do IV antibiotics?
Boo.
No, right? She needs to have what occur? That eschar needs to come off, right? Do we need to do cultures before starting antibiotics?
No.
No, right? She already has proven that she has some sort of infection with the fever and the white count, okay? And this has been 8 days. Most likely she's got some sort of underlying infection. So the biggest thing is getting surgical excision of the burned skin, okay? Getting that source control, and then starting her on silver sulfasalazine, that one, okay? Now, we'll probably admit her, watch it, as long as it doesn't turn into a truly cellulitic type process with, swelling or redness around the area. We don't necessarily need to do systemic yet. Okay, so hopefully her fever and her white count will get better after we get source control, taking off that eschar and starting with the topical antibacterial. Does that make sense? Okay. Maintenance of function, right? Changing those dressings every day to every 2 days. Okay, 24 to 48 hours. Clean dressings are what we want, right? Dry dressings. Silver impregnated dressings may be used. So this gauze up at the top, okay, that's basically silver. There's a word for it. Well, it's a dressing. There's a specific word. I'll remember it as soon as I'm done teaching you guys. But we wrap it around really open wounds to help with that microbial colonization, because silver kills bugs, right? So it's a great one that we use all the time in the burn center. Okay, but we do need to soak it in water, right? It only really works if it stays wet. So these people will be in, like their rooms are even going to be warmer, their ICU rooms, right? Because not only do we have the loss of skin, but we have to now keep their dressings wet. Okay? They're going to have a lot of evaporation type of coolness to them, and so keeping that room even warmer is really important. In terms of splinting, okay, trying to maintain that level of function. Okay, we do it not for comfort, but for function. Okay, so keeping the hands spread, the feet in a normal, so that they don't contract down. Okay, if it's a posterior burn, we'll keep them splinted with the feet up. Really just depends. All right, excision and grafting. Excision meaning we remove the dead skin. Okay, we do this with what's called a WEC blade. Okay, It almost looks like a funky vegetable peeler with one blade where we just cut the skin off. Okay. We're excising anything that is a full thickness or more. Okay. We try to excise down to the level of healthy bleeding. Okay, if we don't have that healthy bleeding, then that skin is still damaged and it's still going to possibly contract. It still can cause a lot of functionality type issues. And so we go down to bleeding skin. Okay, when we take the skin graft, okay, we are taking normally a split thickness, meaning we go through, we take all the epidermis and some of the dermis. Okay. We need to have some dermis in order to have that basement membrane in there to grow more skin. But we take it from another part of their body, so sometimes those are even more painful, right? Because now we're basically causing a deep partial burn or wound from where we took that graft. Okay? So those are actually sometimes more painful than their initial burn. So full thickness, okay, we take that dermis, sometimes depending on where we're going to put it, so face, neck, hands, we'll pretty much take all of the dermis, okay. Normally we take it from the thighs, we'll take it from the back. If they have, again, a large surface area, we'll try to take it from wherever we can. There was one time I think we took it from the scalp, because that was the only place they weren't burned, or hadn't taken a graft from before. Now, full thickness, really, we don't see those contractures, so that's why we really reserve these for the face, the hands, the neck, so that we really have that better functionality, a little bit better cosmesis at the end. But for everywhere else, okay, we'll do a split thickness, and then we'll actually mesh it. Okay, so when you see a burn victim and they look like kind of like this picture, right? It's meshed skin. We took that split thickness, so we took that epidermis and part of that dermis, and then we kind of ran it through a mesher. Think of it as, anybody seen those pie wheels that you have a sheet of pastry and you run this wheel through it and then you spread it and it's meshed? Same difference. So we take the skin off of wherever their donor site is, we run it through this mesher, and now we can cover a large area, a much bigger area of damaged skin. And then because the in between those meshes, right, in between, like in those holes that the mesher made, it'll end up healing from secondary kind of intention in. Okay, so instead of it being, we're replacing full thickness to that area, that mesh, that skin will grow in between those meshed areas. So that dermis will kind of, instead of having to try to heal a bigger area, all of those little tiny meshed holes, well, that dermis on the perimeter of those holes will grow in. Does that make sense? Okay, so they'll still have that meshed-like appearance at the end, right? But it'll take a lot less time to heal because those holes are much smaller than if we were to just leave it open. It may not heal at all if we just leave it open. All right. Circumferential burns, kind of like what I talked about. Okay. These are at very, very high risk for impaired circulation. Think of it, this is like the compartment syndrome of burns. Okay, you have complete loss of elasticity of the surrounding outside tissue. So it's not necessarily damage to the inside, like we see with crush injuries. These are, there's no way for that skin, in order to, it loses all elasticity. Okay, so think of these, you know, this person up here was probably, give an arm, just what I can see, he's at least, it's almost 50%, just from what I can see. Right, so you lose that elasticity, and now we're giving them 700 or a liter a minute, an hour of fluid, okay? So you've lost that elasticity of that skin to really give you that Michelin Man appearance, right? So then it's just gonna go into those tissues and actually cause that edema, and that's gonna cause that compression syndrome, or compartment syndrome, okay? So what we do, instead of opening the compartments, although we still can, the biggest thing we can do is at least open up the skin, that burned skin, and let that elasticity come back. And most of the time that's enough that the patient's compartments can actually then manage that extra fluid. But we do have to cut through the skin. So an escharotomy does not go through the fascia. A fasciotomy does. Okay? We can do escharotomies on basically any part of the body that we need to in order to regain that elasticity or that movement of that body surface, right? So if it's the chest, we'll kind of make an H, so at least the patient can still ventilate. If it's the belly, that's to help prevent from abdominal compartment, okay, or it'll help with respirations. If you are thinking escharotomy on anything, they should be sent to a burn center immediately. Okay, these are not something you should be doing in your clinic. These should be kind of, if it's a large area, obviously airlifted to a burn center or immediately sent to a burn center. Okay. What time did we start?
We're at 41 minutes, ma'am.
41. Okay. So, all right. Hypermetabolic. Oh my God, I can't talk today. It's Friday. Metabolism. Hypermetabolism. Okay. You have that initial right. You have that initial pro-inflammatory cytokine and oxidants release. Okay. Those really increase the metabolic response. Right? If your whole body is having the systemic inflammatory response, normally you use up more calories, right? So what we see in burns, and the more the TBSA you have, okay, in that post-burn period, right, we have this profound metabolic, oh my God, I can't talk today, hypermetabolism and catabolism that occurs. These people need a massive amount of protein, a massive amount of nutrition. Okay, their calorie intake may be way more than their normal. Okay, because we are then trying to account for this hypermetabolism. Okay. Aggressive nutritional support along with rapid wound closure and control of pain, stress, sepsis, to control this hypermetabolic, catabolic state is really, really important. Okay, so that's why when we have a burn center in the ICU with you round every morning, their dietitian or nutritionist is on that team so that they actually calculate every day how much we need to actually feed them, if there's anything else that we need in order to give them, whether it's zinc, whether they're having, changes in their glucose control, like they're either pre-diabetic or they're wildly bitter now because they just don't have the processes in place. Their body's trying to do way too many things all at once. Okay, so hypermetabolic, catabolic state is a very big thing that we have to worry about in these people because of this massive amounts of pro-inflammatory response. Okay. All right, rehabilitation of the burned patient. Again, wound contracture, okay, really just depends. This is one way that we can treat those contractures. It's called the Z-plasty, and it'll take that contracture and kind of cut it in a way that when we put it back, when we put it back into alignment, okay, it'll actually release that stricture and bring them back to not their normal range of motion, but close to it. Okay. All right. Are we there yet?
We're at 44 4 minutes.
Okay, electrical injuries, okay? We have 3 different kinds of electrical injuries. We have electrical current, we have electrical thermal, and then we have flame burns, okay? The worst of these, really, a lot of these actually, you won't necessarily see outward signs of electrical burn. You may have like a burned thumb, you may have a spot on their heel. It really just depends on what area is touching the current and where it goes, where it comes out of the body. Okay, our bodies are great conductors. Okay, so unfortunately, these things, you know, they traverse bone, muscle, nerves. Again, they may show up either looking like this patient, or they may show up with a tiny little burn on their thumbs. But everything in between is now just a mess, because that electrical current went through their body, and it just depends on that underlying. So these people are not going to go home. They're going to get admitted. They're going to be on a cardiac monitor. Okay, we're going to be watching their CK. They're going to be getting the massive amounts of fluid resuscitation. Okay, it just depends. When we think about entry and exit wounds, okay, we really need to ask them like what type of voltage they think they came in contact with. Okay, so if it's just their house, they're doing home improvement, normally it's less than 150. Okay, if they're on, you know, doing highway electrical stuff or commercial building, normally it's going to be greater than 150. It's normally the commercial type or that high voltage that has the extensive underlying tissue damage. Okay, we see this a lot with lightning injuries too. Okay, we admit them to the burn unit. We have continuous cardiac monitoring. We're continuously monitoring the K and the CK. Okay, making sure that their kidneys, that we're giving them enough fluid to keep their kidneys flushed. Okay, we want, and then serial evaluations of those extremities, just to kind of see if we're going to see any outward signs of, you know, compartment syndrome or any other underlying muscle theft that we need to potentially debride. Okay, cord biting, we see this more so in kids. Okay, normally we don't have to do a lot of surgery, at least initially. We may need to do a little bit of debridement, but a lot of times we just split these with the contracture that you kind of see. To allow them to then heal, and then we'll do the reconstruction surgery after they've healed. Okay, there isn't much we can do for these right off when they have the corner of the. Okay, chemical burns. Remember, acids have that coagulation necrosis. Alkalines have liquefaction necrosis. If you have any type of burn, remove that clothing. Okay, unless it's dry chemicals. We're trying to irrigate as much as possible. There are a few chemicals that, you know, like I think it's magnesium, that we don't want to add water to. So hopefully we've had those MDSD sheets, I think they're called, so that we know exactly what type of chemical they came in contact with, so that we know exactly what type of, you know, whether or not we need to neutralize it with something else, or if just copious amounts of water is what we need. Okay, but again, it really just depends on what the person came in contact with. We elevate, we dress, just like a normal burn, okay, and then we split in that position of motion. All right.
49.
49. How many slides do you have left?
2.
You want to just push? Okay, cool. So burn considerations, right? When are we going to actually send them to a burn center? Okay. All of those things, this is not a 100% complete list, but if they have a partial thickness burn greater than 10% CBSA, they have any third degree burns, so full thickness, okay? Any electrical burns, especially lightning, any chemical burns, inhalation injuries, even if you don't know, they just have a little bit of soot around their nose, caution on, or side on the air of caution, right? Just send them, because we'll most likely route them, or at least watch them, to see if they need to have, you don't want to necessarily send that person home, even if it was, oh, I just breathed in a little bit of smoke. You don't know how superheated that smoke was. Okay, so just err on the side of caution and send them to a burn center so that we can watch them. and intubate them if we need to, depending on what we see. Okay? Any burn injuries that have pre-existing medical conditions that could complicate management, prolong recovery, and increase mortality, those would be like your super diabetics, okay, your cardiac patients, okay, people who are otherwise sickly. You know, these people are going to be going through a lot more, and we need to watch them a little bit carefully. And then any burns with any trauma with it, right? They should be sent to at least a trauma center. Okay? Most trauma centers have a little bit of burn, if not a burn center there. If you can send them to a trauma burn center like BAMC, that's great. Okay? Again, we want to maintain that urine output greater than 0.5. Around 1 is our really our gold standard. We want to prevent hypothermia and try to have that definitive skin coverage. Okay, which of the following patients with burns is most likely to be managed without a burn center admission?
Alpha.
Who thinks alpha? Who thinks bravo? Charlie. Delta. Zero. Echo. Okay. So yeah, that was alpha. Okay, admission orders, you've all seen this before, okay? This is nothing really new. I think the only thing would be making sure that your fluid rate and your fluid type are the lactated ringers with, you know, whatever formula you used, okay? And then adding on that carboxyhemoglobin with lactate, super, super important for any type of, like, yeah, I was in a house fire or any type of inhalation suspicion, just get a carboxyhemoglobin. Okay, burn unit. We have, they can take burns, they can specifically, so in terms of those stars, at BAMC, okay, part of ISR, they have ECMO, they can take care of people who have TENS and SJS, okay? A lot of times, especially not during the cold months, but more so during the summer months, I would see a lot more TENS and SJSs because we didn't really have a lot of people trying to keep their houses warm, right? That's when we would see more electrical or house fires, or they fell asleep in front of a personal heater and they accidentally got too hot and they burned themselves, okay? Kind of that goes through the team approach that we already talked about. They are isolated. They have their individual rooms, okay? And a lot of times it is double doored. You actually have to go in, you can gown up, and then there's another door actually into their actual room, okay? Again, that really helps keep the heat inside of their room because you close one door behind you before you actually go into the room. It keeps their actual room warmer, okay? And dedicated surgical suite, yeah, at BAMC at least, they have their own surgical OR in their unit. That was really nice. Any questions on birds? Okay, go to, okay, I think it's like 26 slides-ish. Okay, so hopefully we'll be able to get through these really quick. Okay, all right, so we're gonna talk a little bit about surgical technique, or sterile technique, and surgical assisting, okay? A lot of this is like do's and don'ts, how not to be a jackass on your rotation, okay? How to you know, ease the minds and get have a good first impression with your surgeon. Okay, that's what we're doing. So epidemiology of surgical infections. Okay, we've already kind of gone over this. Post-operative infections remain one of the most common causes of hospital-acquired infections. Okay, it's our bane of our existence, trying to prevent our surgical site from getting infected. Okay, really, really expensive to treat. Okay, 10 billion annually. More than. We have a lot of readmission rates. You know, we do the surgery, they're admitted, we send them home, and if they get readmitted within 30 days, that's a hit against that surgeon for getting a soft tissue infection and the readmission within 30 days of discharge. Okay, so we really try to limit surgical site infections. Okay. What this did, you know, historically was we really had to figure out how do we better control bacterium, how do we figure out what is actually causing that innocuous, like what are we doing that we can change in order to prevent these in the future? Okay. Now it's more so what can the patient do? What can we instruct the patient to do in order to decrease these surgical site infections? Okay. So what we can do is trying to determine the infectious process. So what is the infecting organism? Right. Mostly it's going to be bacteria in surgical patients. The environment in which the infection takes place. So the local response. Are we dealing with a diabetic person? Are we dealing with neuropathy? Are we dealing with some other things that the person has that's making these surgical site infections occur more commonly? And then what is the host defense mechanism? Like, are they already immunocompromised? Like, what can we do in order to deal with these systemically infected processes? Okay. All right. Most of these, they can be from a microbial type presentation, or it can be polymicrobial. Okay, endogenous and exogenous sources. Okay. When you think of endogenous, those are native to the patient. Okay, so they're already colonized. They already have MRSA colonization. They already have. This is why we test moms who are laboring for that group B strep. Okay, because we've figured out that if we can see if they're already colonized and give them antibiotics before birth, that it really decreases those post delivery infections. Okay. When we're talking about most common pathogens, we see a lot of gram-positive cocci. So the Staphylococcus aureus, the Streptococcus, and Enterococcus. And then the next most commonly one is the gram-negative bacillus. So the Pseudomonas aeruginosus and the E. coli. Okay. We also have to deal with Streptococcus epidermis. A lot of times, this is a colonization that all of us have, right? And depending on how much we see colonized within that culture, it could just be what we call a contaminant. Okay. So if it's just a little bit of Streptococcus epidermis, then sometimes we actually have to take more cultures timed out to see, was this a one-time thing? Was this a contaminant? Did we, cross-contaminate the sample, or do they truly have bacteremia caused by epidermis? Okay. When we're talking about enterococcal species, okay, Enterococcus faecalis is the most common one, right? And then when we're talking about the one that's most resistant with vancomycin, Enterococcus faecium. Okay. So these are extremely important to know, right? If you have someone who comes in with, really you're going to see these either in the ED with a positive culture or in the hospital when you're rounding, but if they come back with a blood culture with that bottom one, Enterococcus faecium, then we can't treat it with vanc, right? So what else are we going to do? We're most likely going to probably have to do mirum or some of the enoparums, okay? So it really just depends. Knowing what the bacteria is really, really important, because then we're not just shotgunning the antibiotics. We can really do something specific to go after that bacteria and what it's susceptible to. Okay, so what can we do? Okay, we have these pre-op rituals. Okay, meaning we want it to be aseptic, antisepsis. Okay. We want to try to reduce or eliminate the bacteria from the operative field. We cleanse our hands, okay, reducing the rate of surgical site infections, gowning, draping, masks, the whole bit, okay. All of this, the historics of previously infected people kind of determine what we do now. Okay, so what do we do now? Right? We wear disposable hairnets, skull caps, scrub cap, whatever you want to call it. Okay, our hair is covered. We wear masks. We wear eye probe. That's more so for us and the patient, right? You don't want to get squirted in the eye with blood or fecal stuff or grossness, right? So eye probe is for mainly us. We normally wear scrubs checked in, okay? That really decreases the amount of stuff that we've touched or brushed up against in terms of what we bring into the OR. Okay, shoe covers or having just shoes that are hospital specific or OR specific. Okay, I have my OR shoes that I don't wear anywhere else other than the hospital. Short sleeve only. Okay, so when we do our scrub lab on the 7th, right, we're not wearing long sleeves. We want short sleeves that are at least 2 to 3 inches above the elbow. Okay, you have to scrub all the way to up here. So if you have clothing that touches that, right, that's just going to become contaminated again, and you're going to have to re-scrub. We don't wear any chain springs. We don't wear any watches. They're either stored on our person in our pockets, or we don't wear them. And then name badge, name tape, and badge. That's really so that the OR circulator or the OR nurse can take stock of who you are. Right? They want to keep a list of who's in that OR procedure, so that if a surgical site infection were to come, or if there's a bad outcome, right, they know exactly who was in that OR, and they can do a root cause analysis on what happened. Okay? So having that name badge, 1 means that you're allowed to be there, and 2, that they can keep track of who's been in that room. All right. We will go over this a lot when we do the scrub lab on the 7th. Unfortunately, the scrub lab happens after your test. Okay? So, in terms of what I want you guys to know about this, is that there is a very specific process. Okay? Do I want you to know about this? Normally we have this before your test. I'm not going to ask how many circular strokes, but basically what I want you to do is just have the general idea, right? We're going to start with the hands, we're going to start with the nails, then go down fingers, then we're going to go palms, and back to the hands, then we're going to go wrist, we're going to go forearm, elbows, and above, okay? Again, we'll do this more so when we do the actual scrub lab. But the biggest thing is like if you touch something, you touch the faucet, okay, you touch the sink, you're contaminated. You gotta start all over again. Okay? So that's the biggest thing. Alright, keeping your elbows down, hands up. Okay, we want the dirty water to be dripping down into the sink versus a lot of times you guys, I'll see you guys doing this when you're scrubbing. Okay? Dirty water is now going over what you just scrubbed. So we scrub with our hands up and our elbows down. So during the scrub lab, don't be embarrassed when I say elbows down, elbows down, elbows down. It is ingrained in us that we wash our hands with, in the sink downwards. Unfortunately, in surgery, we have to do it with our hands up. Okay, we want the dirty water to run away from the hands, the parts that actually is going to be inside the patient. Okay. When we rinse, okay, we're not going back and forth in the water. We start with the fingers, get all the soap off the wrist, off the forearm, off the elbow. Okay, it's all upward motion. Okay. Again, if you were to go like this through the water, all that dirty water is not going over your hand and you're not contaminated. Right? You will not scrub correctly the first time. Don't be embarrassed. Happens to the best of us, right? But we do this so that at least before you go off to phase 2, you've done it at least once, and it's me and Dr. Evans picking on you a little bit, making light of it, versus going to your phase 2 site and having the OR nurse or the surgeon actually see you scrub for the first time, and they are, we're trying to put your best foot forward type deal, right? You've already done it once, you kind of already know the process, so that when you get out to your phase 2 and you get to do surgery, to your surgical rotation, so that you kind of have an idea of what you're doing and the etiquette, right? We don't place trash in the sink, okay? We put it in the bucket, okay? Seems kind of more common sense, but you'd be surprised. So, when we get to the scrub, right? Are we then going to be touching our face?
No.
Right? So, the mask, the goggles, the hair, and shoe covers all have to be in place before you scrub. So, What's wrong with these people? All of the things, right? So what's wrong with this guy? No hair cover. What's wrong with this one?
Hair's down.
What about this guy? No eye probe. Okay. What about Dr. Castro?
Hands down, touching pants.
Not wearing a mask. Her shoe covers are coming off. She's got long sleeves and she's untucked. She's got a lot. Okay. What about this one? My ladies with long hair. No hair showing. Okay. You have to wear a bouffant. You have to wear a bouffant. If you want to try to make it a little bit, I normally wear a braid, or I wear a bouffant, and then normally I put something else on. Okay, or I wear my own scrub cap. Okay, but if you have a ponytail or a bun, it has to be in that scrub cap. It has to be contained. Okay, a little bit of wisps underneath is fine. You know, the little baby hairs, but that bun or that ponytail has to be contained within that scrub cap, and a lot of times you just have to wear the bouffant, okay, what Dr. Castro's wearing, okay? What about this guy? No mask, no eye probe. Right.
And smile.
What? He's fun. That's during the scrub lab. Okay? We probably were poking fun at him. Alright, so movement in the OR, right? There is, when you get back into the surgical suite, okay, this is where all the ORs are. This is a specific place in the hospital. There's normally a red line, okay? You come into like the main OR waiting area or where the main OR front desk is, okay? Somewhere down that hallway, there's a bright red thick ass line on the floor. Unless you look like your scrub cap is on, your mask is on, you're in your like the actual surgical scrubs tucked in, wearing your OR shoes, and you're not wearing a jacket, okay? You do not cross that line, okay? That is where we have a lot of, if you get caught crossing that line, and you have not the normally you don't have to necessarily wear the mask, but at least the hair cover, you're not wearing your keep warm jacket, right? You're just in your normal scrubs and your OR shoes and your scrub cap. If you cross that line without those on, you will get kind of your hands slapped and kicked out. Okay, this is an area, and it's on every entrance of where that surgical arena is. Okay, that red line is a do not cross until you are ready to cross it. Okay, you don't have to be sterile, like the slide says, but you want to be ready. Okay. When you actually go into the actual OR, right, you have your mask on, your goggles, your hair is done, you're in your normal OR scrubs, and again, a lot of hospitals will have very specific OR scrubs, like hospital scrubs, not your figs, okay? So a lot of times when you're on your surgical rotation, they'll actually show you where to get those scrubs, because if you go beyond that, especially if you're doing and actually participating with that OR or with that case, a lot of times they'll make you wear a bunny suit, which are fun. Okay. So when you are ready and you are scrubbed, you're wet. Okay. You keep your hands above your waist. Okay. A lot of times I'll have this, and I'll walk back through the door, and I'll wait for the scrub tech to hand me the blue towel so I can dry off. Okay? If I use what's called Apogard, which is a really high intense Purell, okay, I've already scrubbed for the day, this is just the next case. I'll let my hands kind of air dry. I'll still, grasp my hand. I can grab my hands, right, because the other one should be sterile, but you don't take it until you're blue. Okay? You don't touch your body, you don't touch your face. That's why everything's supposed to be ready by the time you actually get into the OR. Okay? And again, we'll go over that a lot more when we do the actual scrub lab. Okay? In terms of drying your hands, there's a very specific way of how to dry your hands. They're a big stickler. Okay? We'll go over that. But basically, you use one half of the towel on one side. You get your hand, your wrist, you pat dry all the way up, and then you take the side of the towel that wasn't used, and then you do the other side. Okay, we'll go over. Normally, you're going to be gowned and gloved by the surg tech. Okay, very rarely do you have to gown and glove yourself. If you're going to do a procedure in the ER or in the clinic and you want to be scrubbed up, or if you want to be gowned or wear surgical gloves, we will go over that. Okay. There is a very specific way on how to actually getting your hands into the surgical gloves, and if you want, I think I have some in my car I could probably bring in so I can show you guys how to do that on Monday. Okay. It's very specific so that you keep the outside of the gloves actually sterile, but you can still touch the inside. Okay, gowning in the OR. Again, we're going to go over this when we do the scrub lab. It's really when you go and actually enter the arms. Okay, you're not going down, you're not going up, you're not going out. You're kind of going into the arm sockets of the person in front of you, actually gowning you. Okay, because they're blue. You don't go all the way outside the scrub. Okay, the gown. That way, if your hands are already out, then you can contaminate stuff. We'll go over all that later. Okay. Again, you're drying. Okay. See how the arms are more so like in their armpits. Okay. Someone will go behind you. See how the hands are not actually through the gown yet? That's how you're going to be initially. Okay. And then when you get to actually putting on your glove, they'll hold it a certain way, and you'll get taught how to do that during the scrub lab. In terms of dues, okay, there's a tie that you have to kind of give off to the patient and you twirl around. If you drop it, it's not great. When you're standing in the OR, you're fully gowned, you're fully masked, you're in your gloves, you can either, kind of sit there like this, because between the chest and basically your belly button and like your anterior axillary line, that is your box. That is your safe space. Okay? Sometimes I'll do this, so like I'm still kind of here. Okay? But you don't want to touch the back of you because someone just touched it with their, not sterile hands to tie you. Okay? So you're kind of here, you're here, wherever you're going to be. You just don't want to drop your hands to your waist because belly button and down is no longer sterile, and above, and basically you get real comfortable with finding ways to sit and stand without actually touching other parts of you. Okay. Don't undo your tie until your gloves on. Don't drop your ties. Don't touch your face. And then what's this last guy doing? What can you tell? So he's doing right? He's grabbing for the towel,
But he's touching
but the
his
other
stomach.
side is now contaminated because he's touching himself. Okay? Alright, how to conduct yourself in the OR? You gotta know your role. And at this stage, your role is a learner. You know nothing. You may know something. Are there any surge techs in here? I think I already asked that at one point. No. Okay. Has anybody been in the OR before? A few. Okay. How anal does the scrub tech and the circulating nurse get with blue drapes? A lot, right? You don't, if you're not sterile, you don't go near them, you don't like look over them. Surgical fields, the sterile surgical fields are blue. You will know. It's bright blue. It's not even this color, it's bright. It's almost like that Gatorade. Bright blue. You won't be able to miss it. Okay? If you are not sterile in gloves, you don't touch those blue fields. And realistically, until you're staff, you don't touch those fields even if you are sterile. Okay? That's the quickest way to get the OR nurse and the scrub tech be really pissed off at you, and maybe get kicked out of the OR, is touching something you're not supposed to touch. Okay? So just don't touch anything. Don't be surprised as well that if you make one too many mistakes, if you're still allowed to be in the OR, They may actually tie you in almost like a straitjacket. They put a gown on you and they tie the arms behind you so that your arms are inside the gown and you can't actually touch it. Okay? That's common. Very common with students, especially ones who made one too many mistakes. Okay? But it's just to kind of help remind you, like, hey, you can actually be close to that sterile field, but you can't actually touch anything. Okay? If you are not gowned and gloved, don't go between two sterile members, right? So if you have two surgeons here, right, don't go through them. You have to kind of try to move them away so that the sterility is on one side and you being not sterile is on the other. Okay? And then in terms of someone who's sterile in a sterile field, if you are not sterile, you do not go between those two. So like if you have the scrub tech and their table and you're trying to get somewhere, you don't until they move that table closer to them. Okay? Because they may turn around and accidentally get contaminated if you are in their sterile field, because in between them is considered sterile. Okay? So they're going to most likely move that table closer to them so you don't go in between those two sterility places. You get what I'm saying? Alright? Don't touch blue. Again, you have the box. Preparing the patient. So normally the circulator nurse, they're unstable. They have not really, like their hands are clean, but not necessarily sterile. They haven't done the actual sterile wash. But they'll put on sterile gloves, and they're the ones who are actually getting the patient ready with the betadine or the chlorhexidine wipe, whatever they're doing in order to sterilize. And then once the surgical team is all gowned up, that's the ones who are actually going in and doing all the blue drapes. Ortho's a little different in that normally they have somebody who's currently already draped, and I've done this before. If they're having to do an extremity, the nurse will, or whoever is sterilizing with betadine, they'll sterilize that foot, and then whoever's sterile, they actually hold the foot up, and then they can do around the leg, right? Put drapes underneath them, over top, so that that area is completely sterile. It's kind of a circus, a nice little dance when you actually have to do a complete surrounding, like circumferential type of the whole leg or the whole foot, the whole arm, whatever needs to be in that surgical field. It can sometimes be a little tricky. There is such a thing as the brain or the blood-brain barrier. Okay, we call that the drape that's in between your operative field and the anesthesia guy or gal. Okay, beyond that blue drape is no longer sterile. They're at the head of the bed. They're doing all the airway, all the sedation, all the blood pressure monitoring, all of the other stuff that while we're actually doing the OR, they're unsterile, taking care of the patient. Okay. A lot of times if you are not sterile, you can stand back there and kind of look over. Sometimes the CRNA or the anesthesiologist will let you kind of look over. You just need to make sure that you're not like really looking over. We do teams beginning of every morning, or at least before every case. Make sure that any special things that we want are in the room, any special equipment, that we know exactly what surgery we're doing, that it's the right patient, the right limb or whatever, right? It's all of the things that you see on your slide, right? This is a little bit of an older one, but it's a checklist that we go through to make sure that what we're doing is what we plan to do. Okay? And that expectations are managed, so that if you want a very specific drug or you want a very specific type of equipment that's in the room, that nurse knows that that's what they want. Okay? And then a timeout is performed just like as if you were doing a procedure in the clinic. We time out, everybody around the room says who they are and what they do, and then once if the allergies have been confirmed, that the antibiotics have been given, that if it's been if we're using betadine, that it's been 3 minutes of dry time so that we don't have an increased risk of fires, all the things, right? Timeout is performed, and then we can go. Okay. Another reason why you guys don't touch anything is the surge tech. They get really anal about, and they should be, with counts, okay? When they open a case, they have a very specific number of everything, whether it's needles, suture, gauze, blue towels, whatever. By the end of the case, they have to account for 100% of everything that was opened in that case. Okay? That really helps prevent us leaving stuff inside the patient, right? If we're in a huge trauma case and we had to pack all 4 quadrants with a lot of gauze, and I'm talking probably 20, 30 lap sponges inside the belly trying to get some sort of compression, okay? Making sure that all 30 of them come out is really important, okay? All right, you have the Mayo stand, okay, that's normally right over like the patient's feet. It has stuff that's used commonly and or a lot. And then you have the back table where it's everything else. Okay, both of those are sterile. They're both covered in blue. You both don't touch them until unless you're sterile. And the biggest thing with the Mayo stand is, even myself, right? I've been doing surgery for a while now. Especially if I don't know that surge tech, I will ask them before the case, hey, I'm gonna be here. Do you care if I grab shit off your table or not? Sometimes they're like, no, you're fine. Other times they're like, yeah, no, don't touch my Mayo stands, right? And you don't touch them. If they have their own special little way of keeping track of shit, fine. Most of the time though, once they know me, they're like, yeah, that's fine, you can grab it, whatever, because they're doing stuff on the back table and I already know what the surgeon needs. That's not a big deal. But you always ask that surge tech to see if that is something that they will allow you to touch. Most of the time in the student status, don't take it the wrong way or don't take it personally when they say, please don't touch anything, right? They don't want to lose something, they don't want to have to account for something that may not be there at the end of the case. Not that anything would happen, but it's on them. Okay, it's their license, just like when you guys become providers, it's on you when you guys do stuff. Okay? Alright, setting up cautery, okay? Bovie is what we normally use. There's normally a grounding pad on the patient, just a big blue sticker. And so that kind of just helps prevent any surgical fires and or arcing or anything weird, okay? You make sure that that's plugged in, we make sure that it's on the patient. When it comes time to taking it off, we want to make sure that if you are the one who takes it off, you're taking it off slowly, especially with old people. If you were to rip it off, you may actually cause a big skin tear, okay? And if you are the one who takes it off because you're being helpful, you then tell the circulating nurse, hey, I took off the grounding pad and there was no skin issues, right? The skin's still intact. That's fine, okay? Suction, we'll set up suction and then trying to pass it off the field so they can actually plug it into the suction sometimes can be, again, a dance to making sure that like you stay sterile, they don't get a contamination on you, and again, once you're actually in the OR, it's a little bit easier to understand. Okay, contamination, you're not the first time you're going to do it, that'll be the last. Even the most seasoned people accidentally bump their elbow or aren't thinking and grab the leg handle while they're sterile. It happens, right? But if someone says that you contaminated themselves, you did. Even if you don't think you did, you did. You don't argue, okay? We just either take the gloves off and put new ones on. If it's a sleeve, a lot of times it's a sleeve, like you won't notice that you're touching something and you're actually, brushing up against the unsterile, suction, okay? It's the big stand of suction. You may not feel it, right? But someone else saw you do it, you just did it. You put in they put in a sleeve, and it's no big deal. If it's an actual gown, like the actual gown, you just unscrub, you go scrub again, no big deal, okay? The hardest thing is to admit to something that you may not think you have done, right? We're all type A personalities. It's not our fault. We didn't do it. Like, I was really careful. I didn't do it. If someone says you did, you did. just don't argue, okay? Trying to give you that, a little bit of a, putting your best, foot forward and not arguing, okay? Be active, participate, assist in the closing of each case, okay? Whether it's staples or, subcutaneous sutures, okay? Help clean up. You're in there to learn. The more you actually participate in each stage, or attempt to participate in each stage, the more impressed your surgeon is going to be, and the better your grade's going to be. Remember, 75% of each rotation, except for 3 of them, are how well you impressed your preceptor. Okay? Your end of rotation exams, you only have 7 of them, and they're only pass-fail, 25% right now. That's it. That's 25% of your grade is your exam. Okay, you still pass it, so don't slough off on that. But the other 75% of your grade for other than 3 rotations, for the most part, are 3 or 4. Are how well you impress and how well your preceptor thinks you're doing in your rotation. Okay, so when you actually get to phase 2, look at your syllabi. Every single syllabi has your rotation specific eval. That's what your preceptor is actually looking off of. Surgery, there's a lot, okay? And if you not necessarily demonstrate everything, you can't demonstrate everything, but as long as you can talk about it, you're gonna do pretty well, okay? Does that kind of make sense, right? You want to be a participant in the actual rotation. In terms of degloving and degloving, you're not taking off the gloves and then fucking fleeing them. Don't do that, okay? I saw a couple people do it last semester in the scrub lab, and don't, because if they're covered and saturated with wet blood, you're now spraying, aerosolized blood everywhere, or fecal material, or whatever you were just doing, okay? You're not flinging shit, all right? Okay, we'll practice that. Movement, a lot of this is common sense. The stronger person's where the heaviest body part is, right? Be on the chest. If you are not so much great at the arm strength, maybe do the feet. Maybe help get the atrium with the chest tubes, or the Foley, or maybe you're trying to get the monitor over. Okay, if they're a critical patient, we hook them up to the monitor before we move them back to the bed. Okay, there's a lot of different things that you can do depending on what your strength ability is. If you see something, say something. Don't be that person that does that, says, oh shit, that IV seems like it's gonna be really taut if we move them. Actually say it, okay? Because someone else may not have actually seen that. And then transferring, rails up, patient's cure, all that jazz. If you get bloody, try not to leave the OR like this. Okay, it's not a great look. I am unfortunately a habitual person who looks like this in the OR, but my job is normally at the end of the case is to take that patient from the ICU or from the OR back to the ICU. So I don't really have a chance to change.
Then you go to Walmart like that, right?
No. I change as soon as I can. Okay? Your job, because you're never going to be alone with a patient, especially a critical care patient, okay? If you have the ability to change real quick before, they start moving, or you go with that patient back to the ICU, or to PACU, and then you change, okay? You try not to leave the OR arena like this, but sometimes it's unavoidable. It just depends on what you've been doing in that case and what your expectations that your preceptor put on you. Okay, so yeah, I'm a habitual one. I'll walk around with just blood everywhere. All right, post-op recovery. Okay, if it's an outpatient ambulatory type surgery, okay, they're going to go to PACU, the post-anesthesia care unit. They have a specific post-anesthesia care unit nurse. They're going to wake up. They're going to make sure that they can void or ambulate or whatever their checklist is to actually be able to go home. If they're going to inpatient, if they're going to tele-med-surg step down, most of the time they'll go to PACU first, recover, and then go to the floor because a lot of med-surg nurses are not recovery nurses. okay? And they have, you know, 1 nurse to 8 patients, they can't do everything one-to-one like they normally would in a PAC. Okay, the only other case would be if they're going back to the ICU, which is again why I normally go straight from the OR to the ICU, because that's my job, okay? Because that they normally have a 1-to-1 nurse, that ICU nurse can recover that patient, and most of the time they're already intubated anyway, so there's not much recovery. They're not waking up from anesthesia most of the time. Okay. If they go back to the floor, med-surg, make sure that you are following up with that patient inpatient. Okay, going to their room, making sure that their pain is controlled, making sure that they're not having a lot of nausea, vomiting, that they're actually peeing, okay, passing gas potentially, and then go back to the case. Go back to the OR for your next case. Okay, it's not just one and done unless it's 2 o'clock in the morning and you're in the emergency service, and that is one of them. Okay, then you just go back to the ER and wait for the next consult and the next time you go to the OR. Okay. Avogard, we kind of talked about this. This is the Purell crack, right? It is pre-surgical. We normally will scrub the first time of the day, and as long as you're not smoking, eating, going to the bathroom, you don't necessarily have to re-scrub. You can just use Avogard in between each case. Okay, if you have very sensitive skin, I would wash your arms and your hands after each case to get the Avogard off your skin. I have eczema, does not work with my skin. I have to wash all the Avogard off my skin or else I break out in hives. Okay, so just be aware, because it's Purell crack, it will, if you have any type of eczema or skin condition or you have just dry skin, it'll probably get worse if you do not wash this stuff off. Okay. Trauma is a little bit different in that normally I'll scrub the first time of the day, and then no matter what I'm doing, unless I'm visibly dirty, I won't scrub again. I'll just use no scrub because I need to be in the case setting up within 30 seconds versus spending 5 minutes to scrub. Okay. We'll go over that. All right. Any questions?